So good morning here in Brazil, good afternoon, guten Tag in Germany. And before we get started here, Shaq, I would like, as most of you probably know, we did an edit case on fetal intervention last year for CSI. So I would like Simone to go over that case because it had some very interesting outcomes. So Simone, why don't you show some pictures of that case we did last year, please? Go ahead.
Okay, so can you get the slides here? Okay, next please. So this is the pre-intervention fetal echo, as you see, LV with a lot of EFE and dysfunction. Next, please. Then the procedure that we showed you, and in the left side, in the right side, we can see the 2 days after procedure, the LV function, not good but a little bit better than before. Next, please. And the baby was born on the 26th of August last year, and this is the first day of life echo. You see here the LV with very bad function still and not very good in size, as borderline LV size, with a lot of EFE, as we can see here. Next, please. We did a next. So the baby was born, as I said, in the 26th in August. Was 38 weeks gestation. And we did an aortic valvuloplasty through carotid approach in the 3rd day of life. The LV didn't recover regarding function and size. We did a hybrid procedure in the 10th day of life. And this baby had renal failure and had a hard time in the ICU. And the 5th day of life, we decided to do a atrial septostomy, not that big, but we had to do that. And the baby then, after that, improved and was discharged in November. Next, please. So this is the pictures showing the LV function and size. As we see in the right upper, we can see the atrial septal defect that was created, and in the lower right, we can see the flow across the aortic valve, but still bad function. And this is just before he was discharged home. Next, please. And still the LV with not a good function. Aortic valve was open, and we still had retrograde flow across the aortic arch, as we see in the lower right. Next. And then 6 months after the procedure, we saw here the patient came for another echo, and we see how the function improved, much better function, but still not very good in size. And we still had retrograde flow across the aortic arch. Next. So the baby was then, at this time, we talked to Dr. Deonido in Boston, and we referred him for LV rehabilitation and biventricular repair. This was done June 5th, this month. And he was 9 months old at that time. He had an excellent outcome and was discharged on the 14th of June and was back to Brazil this week. And I'd like to show you some of the pictures they had there. Next, please. So this was the MRI that was performed before the procedure. We can see the left ventricle was not normal in size, very hypertrophic, but aortic valve and mitral valve were both good in size. There was still aortic stenosis, as you can see here. Yeah, we can see the bands here and the stents. We can't see very well because it's a MRI here. The stent is an artifact here. Next, please.
Next.
So here we can see in this MRI, in these pictures, we can see the right side, the LV, and we can see very clear the EFE all around the LV was completely surrounded in the endocardial with EFE, we can see here. Next. And then this is the cath before the procedure, as we see here. So the LV, very good function, but very hypertrophic and a little bit in the small side with some degree of aortic stenosis. Next. And this is the post-bypass TE. So Pedro, Dr. Deunido did debanding, he took the stents out, and he did EFE resection and a nice aortic valvuloplasty. And we see here, this is the post-bypass TE, as we see, very good function. The LV increased in size immediately after the procedure, very mild AI, and the valve was moving much better after the plasty. He removed, and he was able to make it very, very mobile and competent. And the baby is doing very well now. So we were happy with this outcome we expected. That was our goal, to get him sometime in a biventricular repair. So that's what we would like to show you.
Okay, Chef.
Thank you,
So
Simone.
very nice outcome. Yeah, let's go to the slides for this case, this live case. The patient has been on the table for an hour. The slides for the live cases. Yeah, we're still opening the file here, Shaq. I have some people working with me here, Simone and Rodrigo and Wanda. So next slide, please. So next slide. As you're going to see, my slides are in black and white, and that's because these are the colors of my team, Corinthians, that I root for, and it's going to win against Boca from Argentina, so I'm very happy. So next one, please. So this is the first slide. This is a 60-year-old female weighing 73 kilos. She had shortness of breath and fatigue on exercise, no chest pain, had a history of hepatitis B. Currently, she's on aspirin, metoprolol, simvastatin, and captopril. On physical examination, she has the classic findings of an ASD. A little bit, the pressure, blood pressure is on the higher side. Chest X-rays showed mild cardiac enlargement and increased pulmonary vascular markings. ECG now, she's on sinus rhythm, on a heart rate of between 60 and 70 RVH, and there is some amputation of the R waves in the left precordial leads, and I'm going to explain that. Next one.
It's page 204 on your syllabus.
Yeah, so she was referred to us to close the ASD on at the referring hospital on an echo. She had moderate pulmonary hypertension. She had a cath about a year ago, March 2011, and these are the pressures, RA16, RV 50 over 12, and there was a step up in the sets SVC and left SVC. You're going to see the pictures, 76 and MPA 86. These gave us a QPQS of 1.8 and an index pulmonary vascular resistance of 4.2, and the ratio PVR-SVR was 0.2. There was absence of the hepatic portion of the IVC. There was a left SVC draining into the coronary sinus, and unfortunately she had an adverse event on that cath. There was a thrombus formation in the mid-LAD. You're going to see the pictures, and she had an MI, and this was sort of picked up a little bit later. Next slide. So these are some pictures. The interruption of the hepatic portion of the IVC, the left SVC on the right side of the screen. Next one. Next slide. So this one can see a thrombus in the mid to distal LAD, and this resulted in an MI. Next one. So we brought her back to the cath lab. Next slide. She had a thrombus aspiration and a PTCA, and in that way we restored the patency of that vessel. Next one, she had another cast. Before that there was a little bit of loss at the apex of the left ventricle, as you can see in that picture. Next one, next slide. We brought her back, and 4 months later, the LAD was still patent. There was a bit of recovery of the left ventricle. You can see that on the right side of the screen. Next one. And these are the pictures of the ASD. It's a central ASD measuring around 14 to 17. There is our right ventricular volume overload. Next one. So the intended, next slide. The intended intervention here is transcatheter closure of the ASD through a transhepatic approach using a fenestrated Figulla device. There were some concerns about the diastolic function of this left ventricle, and we're going to close the hepatic tract using a vascular plug. We are back. I would like to show you some pictures that were recorded. Can I have the angel, please? Angel. So you can see in that screen I did the transhepatic approach. I used a transeptal needle, a Brockenbrough needle. You can see it's being advanced through the liver. I'm the second last intercostal space. After we inject some dye till we find a vessel that leads us to the IVC. There is some dye going through that vessel. Then we reach that vessel, inject some dye. There is a good-sized vessel inside the liver here. Then we lead a coronary wire through the Brockenbrough needle. We reach the RV and then the left SVC. We are taking out the Brockenbrough needle here.
Carlos?
And there is the... Sorry?
Carlos, do you use the Brockenbrough needle for transhepatic punctures routinely, or this was different from what other people do?
Not routinely. Yeah, that's a very good question, Shaq. We don't have a very long Shiba needle, and we ran out of a biopsy needle here. We work at a cardiology center, so we don't have those hepatic biopsy needles. So, and I think, to be honest with you, Shaq, I think it's a very good tool. It worked very well. It's an 18-gauge needle. It went through smoothly. So I've done that a couple of times. So I'm very confident that it works. So that's why I decided to use. I had to adapt the tools here to our own environment. So. Yeah, in fact, I straightened out a little bit. I left a very slight curve at the end. If you want to see how it worked, I think I still have here on the table. Let me show you. Here, my hands.
Anybody else used Brockenbrough needle for transhepatics?
Zoom. Zoom, more zoom, more zoom.
Nobody.
More zoom. So it's straightened out. You can see not here, the tip, here. Yeah. You see, it's almost straight.
Okay.
Just a slight bend.
So
okay.
It's the 0.5
Then of course yeah, more or less. Yeah. And then we dilate the tract using a radial sheath. This is a 6 French. This is a radial sheath going through the liver again, and then we exchange for a longer 6 French sheath. We kept the wire in the left pulmonary artery. There you go, and this is the sheath. We kept the wire. We were in the right spot in the right atrium. And then we did some more things, and then I would like to show you the pictures of the ASD, right? Would somebody else do it differently, coming from above, coming from the SVC? I think it's quite cumbersome coming from above.
Let me just ask one or two people. Mark, you put your hand up. Or were you having a stretch?
Okay.
Can we switch the microphone?
It's on. Just speak into it, Mark.
Try it.
Yeah, no, I don't have experience doing transhepatic, so I probably would have gone from above.
Okay, and remembering there's a dilated coronary sinus with left SVC into it.
Alison?
Exactly.
Alison? Sabelka?
I think I don't do a lot of transhepatic either, but I think it makes sense for this. Also, it's difficult. I've done a ductus from above, but I haven't done an ASD.
Okay, Raul?
Makes sense.
Raul?
I think going transhepatic is easier than going from the jug.
Okay,
Two people
Oliver?
at the back.
Yeah, I had a woman with left isomerism, and presumably this woman has left isomerism too. And we just did it from the subclavian vein.
Yeah,
it was
great.
perfectly straightforward.
And remembering there's a dilated coronary sinus as well. Any impact from that? Oliver?
To be honest, I don't remember if she had a left SVC. I don't think she did, actually.
Chances are she would have done if she was isomeric.
But we paced her from the left.
Yeah, let me show you
side
some echo
subsequently,
pictures.
so
Peter's got a
she
comment.
What is
Yeah,
it?
let's see the echo pictures. Carlos, hi, it's Neil.
Echo, please, guys. Echo,
Peter.
and then
Peter, go
Simone.
ahead.
I just wanted to
Echo.
ask, what is your principle
Echo
of
on
anticoagulation
screen.
due to the bleeding complication risk?
Atrial fibrillation?
We've already...
Anticoagulation.
Oh, and
Yeah,
anticoagulation.
after we secured the... After we secured the lines, we've given 5,000 units of heparin. We ran an ACT. We had to give a little bit more, 2,500, and then last ACT was 265. And after that, we gave some more heparin. So the total dose was 10,000 units because we've been working for 2 hours almost. So let's go to the echo pictures.
Okay, so we can see here the 4-chamber view. Right chambers are dilated, and we can see here the very dilated left the coronary sinus. Going up a little bit, we can see the ASD. It's a mild to moderate ASD, very good size and position. Left to right shunt, as we see here. Good rims around it. We measured 14, and then some more pictures here. 13.6, and then we can see that it's more anterior, more close to the aorta. This is the bicaval view. As you see here, there is no here. This is the other measurement, about 16 millimeters, and this is the color flow. So we looked at the 3D pictures, as we can see here. This is the ASD. It's a round ASD. This is just some dropout. So the ASD is here itself. As we can see, this was the left side. This is the right side. And it's a very round and well positioned with rims around it. So I think there are no problems regarding with this case.
Okay, thank you, Simone.
What would you do? I mean, would you be worried about the LV function? Because there were some concerns about the LV function. Simone, can you show us the Doppler across the mitral valve in the pulmonary veins before we did the test occlusion of these ASD? Can you show us?
Sure. So we have here the trace in the mitral valve tracing Doppler, and we don't see any specific changes or abnormalities here. And that's the pulmonary vein Doppler. We can see a triphasic tracing with no significant A-wave reversal. So in this setting, she didn't have significant LV diastolic dysfunction in this
So Carlos, where was
specific moment.
How was the concern raised about the diastolic dysfunction? What was the reason for that?
Yeah, well, I know this is an older lady who is on simvastatin. Her cholesterol levels are are high. And she had an MI due to a mistake we did last year during the catheterization. So I was a little bit concerned about the systolic and diastolic function. The global systolic function is okay,
and
right?
The current left
and then,
atrial pressure?
well, the plans, that's why. Yeah, well, the left atrial pressure is exactly the same, the right atrial. Now, I forgot to mention that, sorry. I had here, there is normal PA pressure, around 35 over 14. We had 10 on the right atrium, 10 on the left atrium. I had a left end diastolic pressure of 10, right? But then when we closed the ASD, and I did that, I used a new MAD balloon. Let me show you the new MAD. This is the sheath going through the liver. This is a 12 French sheath. In fact, I positioned the sheath, but the sheath was too long for the length of the balloon, so I had to take the long sheath out. I put a short 12 French sheath, and then I slid the balloon. And then when I closed the SD with the new MAD balloon, and this is the strata diameter 20.6, I had the same thing on echo, we're going to see in a minute. The left end diastolic pressure increased to almost 20. And I have a catheter coming from below, as you can see there, and it's wedged, and the capillary pressure was the same. So increased from anywhere 10 to 12 to 15 to 20, almost 20. So I think there, and then the wave pattern did change a little bit on echo. Can you show us, Simone?
Yes.
So let's go back on echo.
So we got another pulmonary vein tracing, and you see here that there are some A reversal appearing. So not very worrisome, but a little bit of changes in this tracing, as you see here, after closing the ASD with the balloon.
So, Shaq, how many of you would put a regular device? How many of you would put a fenestrated device in this situation, okay, that there was a little bit of increase in the left-hand diastolic
Carlos,
pressure?
this is a question right up the street for Alison. Alison?
Carlos, hi, it's Alison. I would not have been so concerned until the history of the event at the previous cath, because her hemodynamics at your first cath looked very favorable. Perhaps she could just be conditioned or treated with medication and closed with traditional device. Or if your fenestrated device will close spontaneously as she conditions herself, that would also be favorable.
So right now, if you had to pick a choice, make a choice, what would you put in?
Marshall. Marshall.
Pardon? What did you say, Alison?
Alison, come on.
Alison, what did you say? Fenestrated
Either
or
medications and then closure with a regular device. I don't have a fenestrated device.
No, we're here now on the table.
We've got transhepatic.
I think it's okay to use a fenestrated device and treat her.
Marshall.
I think I will go with treatment and then bring her.
Oh,
after
come on.
3,
We're on the
6.
table now. We have a sheath in the left atrium.
Yeah.
We're not going to...
So no choice.
So what you're going to put in...
Device.
No, there is a choice. The fenestrated device or a regular device?
No, fenestrated device.
Fenestrated
Mark?
device, okay.
I know you're stretching again, but...
I'd probably go for the regular device in this patient.
Regular device. Caesar? Caesar?
Me too, a regular device.
And behind you is...
We have a lot of experience closing ASDs in this patient. Actually, with these hemodynamics, actually go ahead and close it and give it a little bit ACE inhibitor later, and that will be fine.
Okay, so show of hands, fenestrated device.
1, 2, 3, 4, 12.
Shaq, was there also not an abstract in the poster? And I don't know if that person is here. Perhaps he or she could comment.
Okay.
On the unreliability of balloon occlusion hemodynamics.
Okay, we'll try and find that person. All right, regular unfenestrated device. The vast majority are voting for non-fenestrated device. And is the person here with the had the poster? Who was it?
Okay,
No, okay.
Shaq. So we have 10 minutes to go, I think.
Yeah, you carry on.
So I made a decision here. Yeah, and I decided to use a fenestrated device because, as Alison pointed out, it can close by its own. I've already given some diuretics here on the table, but I'm going to use, I think it's safer, at least in the immediate pause period, to avoid some pulmonary edema. And most of these fenestrations, they close by their own. So I'm going to use a custom-made Figulla device, which I'm going to show you in a minute. Can you drop it out? Drop here? No. Yeah, take it out.
So,
Carlos, yeah, let me show you.
It's very good.
This is the, yeah.
It's very good strategy never to listen to experts in an audience, because that can be a recipe for disaster. So you do what you want to do.
Shaq, you know me. Yeah, I'm a little bit stubborn, and I think that's one of the key issues on live cases. You should do what you think it's best for your patient. Exactly. I think we have all the tools here. Yeah, and I made that decision, and I'm happy that at least 1/3% of the audience agreed with me. So this is the fenestrated device. It's a regular Figulla device because we had 20.6 both on echo and on angio. This was the stretched diameter.
Carlos,
this is a 21 millimeter device.
Just move your left hand away from
and there is.
Yeah, that's better. We can see the fenestration.
There you go.
Yeah.
Now it looks better, huh?
Yeah.
Yeah, you can see a 4 millimeter fenestrator. It's close to the central portion of the device. This is the left side of the device. This is the right side of the device, right? This is the new Figulla device, new at least for us, because it's connected through a sort of bioptome mechanism, as we're going to see in a minute. So
Carlos?
I'm going to load the device. Yes.
You carry on loading. I won't stop you, but how did you decide on a 4 millimeter fenestration?
Oh, that's very, it's empiric. Yeah, I mean, there is no, I think, good data to make that decision. So I asked them to make 4 millimeters hole. Okay.
It was really to help it close on its own, wasn't it?
Works most of the time for fontans, for patients with pulmonary hypertension. So it's being connected here, right? So it's a bioptome. Is it locked? Tá preso? Yes, so it's locked. So I'm going to load the usual way here. This is a 12 French sheath, regular sheath here.
Shaq.
So I'm getting rid of air here.
Mansour, can we ask him to put a wire through that fenestration and measure for us the hemodynamic after device deployment? Is it possible or no?
Carlos,
well, it is possible, but I don't think we need that because, you know, the fenestration is going to do its job. So we did that for fontan patients in order to secure the fenestration. So I think it's going to make the procedure more cumbersome. We could do that, I agree. No. We've done that in the past. You can
Carlos,
even put a stent through the fenestration.
No,
Carlos,
don't worry.
You have a wedge catheter in place anyway, so...
Yeah, I do have. You're right, Neil. Yeah, so let's show my hands here. Yeah, zoom. Yeah. So I'm doing the transition here.
What's the size of the device? What size is it?
22.
21. 21.
Oh, yeah.
We had a waist of 20.6. Right? Both on echo and on screen. So I'm going to go live.
Yeah, Carlos, there's a question or comment from Abe Lover.
There are two ways of fenestrating such a device. One would be as Carlos has proposed, and there might be another way to fenestrate the matrix without touching the metal. So if you leave the metal intact, actually you predict that within several weeks or 3 months it will be totally closed by, doesn't matter what the size of the fenestration.
So you make the hole yourself with the dilator or something, yes? Is that what you're suggesting?
You don't touch the mesh, it should be cut out.
Yeah. Okay, carry on, Carlos.
Okay, yeah, I'm told that I have 5 minutes, so I'm going to open, I'm in the left upper pulmonary vein. In fact, I had a little bit of a hard time because of the very dilated coronary sinus. I had a hard time to go into the left upper pulmonary vein. I'm going to open the left atrial disc here. I'm still a little bit far away from the septum.
Can we get TOE
there you
pictures?
go. It's open, right? Yeah, can we go to the echo picture, please? Echo picture. Echo, please, guys. Echo, much better. There you go. So I think the angle is not bad here. I'm going to open the waist here.
Carlos,
can you go
ask
picture
them to
and
remove
picture?
your hands, the camera on your hands, and just have fluoro and echo.
Yeah. Angel, small picture, angel. A menor a angiografia, não a minha cara. Angiografia. Tá? There you go. So I open the waist up. I'm going to bring everything back there, almost there, right? So just keeping the position of the delivery cable as usual. I'm going to open up the right disc. So I think the device is in the right spot. Let's see if the fenestration is working.
What time did you put
See,
the
can you go over the echo pictures?
Sorry?
It's close to the central portion of the device.
Was that your question?
It's through the waist.
Rafael, was that the question?
Yeah, I think
it's... I wanted to know if it's 3 o'clock p.m. or a.m.
Well, in Brazil, it's certainly a.m. That looks very nice, Carlos.
See, can you go over? Yeah, let's see the pictures. Maybe we could go afterwards with 3D TE.
Yeah, just checking the position. I think it's in a very good position now. The shunt comes only from the central part of the device where the fenestration is, as you can see here. So
lovely, Simone.
I think it's perfect. Yeah,
very nice.
Very good.
Carlos, just
Neil, I had left end ventricular, left end diastolic pressure is 10, and I have a wedge of around 10 to 12. So this answers that question.
That sounds good. Are you happy with that? The doctor who asked the question?
Yes,
I'm
happy.
Happy?
Yes.
Yeah, we're happy. Thank you.
One question.
So now we have some 3D pictures before we release this device.
Carlos, another question.
Yeah, when you released the device, there were some spontaneous echoes in the right atrium. What is the risk of bubbles in this custom-made device? Air bubbles.
Well, I mean, we see those micro bubbles all the time when we open the right atrial disc. I'm not sure if there is more risk of air bubbles entrapment within the device. We were pretty, we had a very strict care loading the device. I'm not sure. What do you think, Shaq?
Yeah, well, I think we see these micro bubbles in the regular routine anyway, so I don't think they were more excessive.
Yeah.
Simona, that was a lovely picture of the 3D picture of the device with the fenestration through it. Could you just put that up again for us, please?
Yeah. Sure.
Yeah, we have 2 minutes before we leave, before we release the device.
Just a second.
Well, you can release it. We can still talk. We can still see the images.
Yeah, I can. Well,
Simone,
I'm going to do that right now.
I just wanted to
I'm going to release the
Simone's
device. Can I do that with? Yeah.
Dr. Feldman,
may I release the device?
Yeah. You are ready to. Yeah, we'll show the fenestrating afterwards. We can release the device now. Okay, it's released.
It's released.
Okay.
And now we can get nice pictures.
Very nice.
Here.
And then whilst we're getting the 3D echo, can we put the echo big now? And
echo big, please.
And Carlos,
echo grande.
Do you then close the transhepatic tract or not?
Yeah, I'm going to do that, Shaq, with a vascular plug. I have some LifeTech plugs here. I'm going to use, I had a 12 French sheath, so I think I'm going to use either an 8 or a 10 millimeters plug. It's very similar to the Platzer vascular plug 1. to be on the safe side.
Okay.
I mean, because of heparin and...
You've probably got less than 1 minute, so,
So,
maybe
me
we
dá
can do
o-
that.
Yeah, abre esse, me abre a bainha, o catéter, isso. Yeah, let's go. Pode abrir esse. While Simone makes some comment, would you like to make some comments while I work here?
Yeah, yeah. So we see here the device. This is a left atrial view of the device. It's not that clear, the fenestration here, but if I take some of the gain here, it's not that clear as before. Okay, I'll do with some color flow.
So, Carlos, we'll stay with you a couple of minutes if you are getting ready for the transhepatic closure.
Yeah, I think I am here. Oh, I lost my microphone. Meninos, meu microfone. Meu microfone. Precisa arrumar.
We can hear you.
Contraste aqui. Contraste. You still can hear me? Yeah. But it fell out of my ears. So now I'm with Can we make the angel bigger, please? Angel bigger.
Very nice fenestration picture there.
Let me show you.
Thank you.
Yeah, now I'm bringing everything back. So this is the tract.
I think you're already out, no?
Yeah, almost.
No, not almost. You're outside
I think
the
you're
capsule
outside
now.
the liver.
Well, you better press.
Maybe you don't need to. John, what would you do here?
Yeah,
reading.
okay.
Nothing, I think.
Okay. One of our radiologists, John Reedy, says he wouldn't do anything now.
It would be very difficult to get back, wouldn't it? And I think fiddling around, you can
Dá
do more
8,
damage.
8, 8, 8, rapidinho.
I should just put some pressure on the liver there. I think you'll be okay.
Yeah, that would work too.
We don't want you to start stabbing again. Because getting in the exact tract would be extremely difficult
Okay,
and hazardous.
Carlos, just summarize what you're going to do now. Just take the sheath out and press, because we're ready to go to Frankfurt
Yeah,
live.
I'm sliding an 8 French
No.
catheter here.
No.
It's not going through.
Carlos, I should just press. And
Yeah.
It'll be
No.
all right.
Yeah, me dá plug vascular Amplatzer. 10 milímetros.
Maybe reverse
I'm going
the
to use,
heparin
I'm
and
having a
press.
hard time here.
Dave?
So
No,
how
you're
about the
doing fine. You're doing
anticoagulation?
fine, but you're out of the tract.
Reverse the
So
heparin and press on.
Yeah. So the suggestion from pretty much everybody is reverse the heparin and then press on the liver or something, and don't try and stab it again or put a plug.
Well,
That's pretty outside.
I always close those tracts and
yeah,
Yeah, but
I
only
think
if you're
that's a
in.
good idea, but you're outside it now, Carlos, and I think if you close
Yeah.
anything, it's going to be the distance between the liver capsule and the skin.
precisa tirar esse aqui. Precisa tirar, cortar.
Carlos, we're going to have to go to Frankfurt now, so we'll leave you.
Good luck
Yeah,
with
I'm going to
that.
show you the pictures. Yeah, I'm going to show you the pictures.
Later
We're
on.
coming back anyway.
We're coming back to you, so thank you very much for excellent demonstration
lovely.
again.
Okay.
Yeah.
Okay, thank you. I'm going to show you the pictures.
Okay.